I'm going to talk about primary care and answer the fairly basic question, if I can. If there are more family doctors than ever before, why can't I find one? This work was conducted on the ancestral, unceded, present, and future territory of the Mi'kmaq. I also had previously worked up to a year ago on the traditional Coast Salish lands of the Musqueam, Squamish, and Tsleil-Waututh nations. Thanks for funding from CAHR and Canada Research Chairs. And I have to tell you that the access to data provided by data stewards is subject to approval, can be requested through research projects, but I can't share it. And any inferences, opinions, or conclusions drawn do not reflect the policies or opinions of data stewards. So my plan for today is to cut right to the chase and tell you some of my key findings up front. So if you're zooming in from somewhere and have a busy day, hopefully that gives you at least the high level snapshot. I'm then going to step back and provide a little bit of context for why we're asking these questions and try to answer two sort of pieces. So I'm going to present some of the completed research on how practice patterns of family physicians are changing over time and a kind of focus question about our different choices among early career family physicians driving these changes, which is a really common narrative that we encounter within primary care. And then I'm going to share some work in progress around what other factors may be driving changing primary care capacity. I'll suggest some next steps, and I've been thinking through some opportunities for possible New Brunswick collaborations here, so this is a chance for me to throw that out there. And then I'll end with some time for questions and hopefully discussion of implications. I don't know the New Brunswick context as well as I'd like to, so I'm hopeful that there might be some comments and questions and dialogue on what this might mean for medical education, as well as primary care policy and workforce planning. Okay. This is the work of a huge study team to get this work done across multiple provinces. We have PIs, co-applicants, and staff in each of 4 provinces, and this really represents a collective effort. I told you I'd cut right to the chase. So no surprises first. Primary care practice patterns are changing, and I have the data to back that up. The study that came out Monday shows that family doctors are seeing fewer patients over time, and I'll share some data about how their practice is changing and they're working in fewer settings. Some physicians are responding to system and community needs through focused practice, but we don't see any evidence that changes in practice patterns are unique to physicians early in practice. And I'll show you the data to back that up shortly. These findings point to changes needed in primary care systems to meet patient needs, not really gaps in family medicine training. We did interviews with family physicians and found that they're really committed to providing care that meets community needs, but practice and payment models have to support this. We don't see evidence that declining comprehensiveness is driven by preparation or inadequate training. And many people we interviewed are keen to provide comprehensive care that meets community needs, but find little opportunities to practice in this way. Finally, looking forward, we need to do a better job of incorporating this data on changing practice patterns in planning for workforce capacity. So I'll talk about some work about how population aging combined with the complexity of patients means that time spent per visit is likely changing. Administrative workload and time spent on coordination of care in the community may be increasing substantially, and that's an area I'd like to look into in more detail. And so even with an increasing per capita supply of family medicine physicians, additional resources may be needed to ensure patients can access the services they need. Are we good? Can folks see me? Can I? Yeah. Okay. So I'll take a step back and provide that context. This comes as a bit of a surprise. Oh, you guys can see the bubbles too. Okay. When I tell my family or friends that we have more family physicians in Canada than we ever have before, ever. That's true nationwide. I'm going to add a bunch of squiggles to the diagram. So these are the 4 provinces that I have data for, and also New Brunswick. It's true across the board. In fact, New Brunswick is, I think, above the Canadian average with respect to family physicians per capita. And that sustained upward trend is present everywhere. So this comes as a surprise because it really feels at odds with people's experiences of trying to get care where and when they need it. We see headlines and concerns about a family physician shortage receiving national media attention. And we really do see changes in patterns of access to care. I'm going to just try to minimize this for folks in the room. Access to primary care is falling. When we look at data from a national survey, we see that the percentage of people with a regular medical provider or place of care has fallen over a 10-year period. And inequities in who has a regular provider or place of care are growing wider. So those gaps with respect to household income, whether you own your own home, whether you've recently immigrated to Canada, or whether you're racialized in the Canadian context, it's getting worse, not better, in terms of who has a regular place to go to. This is administrative data and just from British Columbia, but to get a little bit more granular, 20 years ago, we saw an income gradient with respect to who had a regular or to use of primary care, with people who are living in poor neighborhoods using more care. That's to be expected because of poverty creates illness. But that has collapsed over time. And the percentage of people with no ambulatory primary care visits has increased most dramatically among people in the lowest income quintile in British Columbia. ED visits have expanded, so it's people in lower income quintiles who are using more emergency department visits. And then really concerningly, a gradient has emerged in specialist referrals over time. So you can see these are falling, but they're falling fastest among lowest income quintiles. So gaps in access to primary care really shape people's movement through the healthcare system and their opportunities to access services needed elsewhere. So one of the things that has come up when I've presented about evaluation of payment reforms or other primary care policies is, might have worked, except that younger doctors just aren't working in the same way. So this is just a snapshot of press coverage from around the time we were starting the study that speak to the fact that more recent cohorts of family physicians may be prioritizing work-life balance, lifestyle may be more important, or they might be working in these smaller niches or focused practice within family medicine. And so this is a narrative that it's hard to sort of get your hands around because it surfaces in different places, but has definitely been very present within the primary care community and sort of service delivery context. So we wanted to look into this a little bit more depth. This also aligns with just our common pop culture explanations of generational differences. This is a real snapshot. You can tell by the ResearchNet and Casper tabs open for me that these expectations applied to the physician workforce align with more popular expectations and different sets of priorities. So, prioritizing the avocado toast over sustained investment in home ownership. So our goal in this study was to provide new information about the family physician workforce with a focus on early career physicians to look into these narratives in some more depth. So we set out to do two main things: use quantitative data to compare practice patterns of early career and established physicians, determine if changes over time reflect cohorts. So if they're specific to that most recent cohort of family physicians, or whether there are changes over time across all physicians. We also did interviews to think about the values and preferences shaping practice intentions and choices of family medicine residents and early career physicians. And our goal is that in understanding factors shaping practice intentions and choices, we can shape future supply of primary care services and hopefully make sure people can access services they need. So we did interviews, over 90 interviews across 3 provinces on those factors that might shape practice intentions and choices. So personal characteristics, training, as well as the policy environment and practice opportunities. And then we used linked data in each of 4 provinces that let us look at average number of visits, continuity of care, and comprehensiveness of services provided, and tried to pull these together for a more complete picture of changing practice patterns. So for more information, the study protocol is out there. You can Google it, or it's on this website, or send me an email and I'll point you to it. Okay, so that first couple questions that I told you I'd answer: how are family practice physicians' practice patterns changing over time? And are these different among early career physicians? So what we're trying to do here, we know family practice is changing, but we want to pull this apart to see if changes are specific to the most recent cohort of physicians, so these cohort effects. And this is important because this would tell us there's a need for targeted intervention during training or early practice to help make sure that family physicians can meet patients' needs. There's also the fact that there will be changes over the course of physicians' careers. In sort of research literature, this is referred to as an age effect, something that is happening at the individual level. So here we're not talking about chronological age, but years in practice. So we may well need to consider aging and career stage in workforce planning. Or finally, do we see changes over time in work and policy contexts that impact all physicians or period effects? And that would point to broader policy responses addressing the context in which all physicians practice. So we're trying to disentangle the relative effects of age, period, and cohort on measures of service volume. The first set of analyses use median polish, an approach to separate these and plot this in graphs. And then we have some regression-based approaches that I'll share later on. So across the 4 provinces, the average number of patient contacts per physicians has fallen. So this is British Columbia, Manitoba, Ontario, and Nova Scotia. These are fairly different provinces with respect to demographic makeup, choices around primary care, compensation, and organizational structure. Yet the finding's pretty consistent. What I want to be very, very clear is that fewer patient visits doesn't mean family physicians are working less. Over this time period, the population has aged, management of chronic conditions has changed, and the health system has grown more complex. And I'll go into some of those factors in more depth later. When we look at other measures of practice volume, so the number of days billed per year, patient contacts per day billed, and the average number of unique patients seen, those are also falling across all the settings we looked at. So getting into that median polish analysis. So these lines reflect those period effects. So changes over time across all family physicians, like we just saw in the bar graphs, compared to 1997, the earliest year that we are looking at, the median number of patient visits has fallen in all 4 provinces. Good. Okay, now those age effects or years in practice, so changes over the course of physicians' careers. Just a note, Manitoba, we weren't able to go back as far, so we only see the first piece of this. But for the median physician, the number of patient contacts increases in early practice and then falls in later practice. This makes sense as you build a patient panel, as you get established in practice, or then as you make different choices as you approach retirement. We see this really consistently across the settings and cohorts. This is not real data, but this is meant to illustrate if we were seeing cohort effects. So if recent physicians were having fewer patient contacts relative to previous cohorts at the same stage, we'd see something like this, where the line drops below 0 as we get to those more recent cohorts, compared to the reference period indicated by that dotted line. Instead, what we see is this. So there's a fair bit of noise on the among those very early cohorts, and that makes sense. There's super small numbers there of people who started in the 40s and are still in practice. But then if you look at those cohorts entering in 2009 through to 2015, there's no evidence that that's falling below the line. If anything, it's ticking up ever so slightly. Continuity. So we're able to look at another facet of practice. So of all the patients that a physician saw within a year, this is the proportion of all those patients' healthcare interactions that were with the index physician. And this fell slightly in Ontario, but has been relatively constant. It's not the best measure. It doesn't account for team-based care. There's some limitations. But as with service volume, we just don't see any evidence that this has changed differentially by career stage or by a cohort. That, again, we're not seeing these lines dip below 0. So service volume and comprehensiveness, I'll talk more about later, are declining across all years in practice and also across the genders we can observe in our data. Changes in practice patterns, however, are not unique to physicians in early practice. Changes may reflect increasing complexity of care, administrative burden, or different choices of work that are across all family physicians. But this narrative of sort of intergenerational blame only serves to distract from broader issues in primary care practice. And one of the things we heard from the interviews is that these sort of this perception that people were working less and not carrying their weight was damaging when layered with the fact that family medicine is already felt to be undervalued compared to other specialties. So again, for more information, I'm senior on this. My colleague David Ruddler in Ontario is lead. This just came out on Monday, and I'll but all the details are here. So I'm then going to turn to another facet of family physician practice, and that is comprehensiveness. So declining comprehensiveness of family physician practice has been a topic of ongoing concern. Some speculate that this might reflect that more recent cohorts aren't interested or don't have adequate training to deliver a wide range of services. And some data do show that physicians who have recently entered practice participate in a narrower range of services than those in established practice. But as with service volume, whether comprehensiveness is changing more rapidly among early career physicians relative to those in established practice isn't clear. This is like one of the classic graph crime images to show bad representation of quantitative data, but this shows that there was concern about the percentage of doctors doing comprehensive family practice back in the 90s. We have been talking about this for quite some time. So this was a bit more challenging to measure than just straight up service volume and continuity, because we're pulling billing data from 4 jurisdictions and trying to look back in time. So what we were able to do was identify 7 service settings or types of care that would be delivered out of office, and 7 service areas that would be typical of office-based practice that we could consistently track over time and across 4 steady provinces. These align reasonably well with what the College of Family Physicians identifies as domains of care for family medicine and builds on some previous work, but it's not perfect. There are lots of sort of important facets of practice that we're not able to capture. So here we're just looking at 2 points in time at the number of service settings and service areas in which physicians are active. We use again, this is the regression-based modeling where we're able to adjust for physician administrative sex, so what's recorded with the college, practice location, practice volume, and location. And we're looking to see whether there is an interaction between year and years in practice to show us these cohort effects. So changes over and above career stage and calendar year that would be present for everyone. Before I get into that though, to do this analysis, we wanted to focus on physicians who are in sort of typical community-based practice and not folks who are doing exclusively emergency department visits. Our measures of comprehensiveness wouldn't make sense for that. So we applied exclusion criteria to identify physicians who are doing 80% or more of their care in other specific service areas or settings. And so this is interesting in and of itself, in that the percentage of physicians who are doing focused practice settings, especially, so the green chunks of these bars has increased across all the provinces, a little less so in Manitoba, but this is pretty substantial. So that mostly reflects people working as hospitalists or in emergency departments. But what I want to emphasize is that the percentage of excluded physicians actually within their first 10 years of practice actually fell. So we're not just excluding the younger physicians. This actually increased more substantially at later career stages. So put differently, focused or low volume practice is not increasing more rapidly among early career physicians. So looking at the data for comprehensiveness, this is simply showing the average number of service settings per family physician. This has fallen over time. So there's the early year, the later year, and then where it drops below 0, that's just showing the change by career stage. But it has fallen again among all career stages. Arguably, it's fallen less among physicians within their first 10 years. Oh, I just want to actually emphasize too, though, there's always been a little bit of you ramp up, you deliver more you provide more services at mid-career, and then that falls down, just as we saw for service volume. I will breeze through this slide, but for those who care about the regression modeling, I just want to call your attention to it's the interaction effects along the bottom that we're looking to as that test of cohort effects. If it were true that family physicians early in practice are declining in comprehensiveness more rapidly, we would look for an interaction between for less than 10 years in practice, a year less than 1. In fact, they're not significantly different from 1, but if anything, they're inching above 1. Switching to service areas, we see less of a change. So the average number of service areas per family physician has fallen slightly, but this is smaller. So within office-based practice, this is changing less, but once again, changes are similar across all career stages, and we don't see regression coefficients different from one reflecting that cohort effect. So on average, family physicians practiced in fewer settings compared to in the later year compared to the earlier year. Findings are very consistent across the 4 provinces, even given very varied models of payment, but we simply don't see any evidence the comprehensiveness declined faster among physicians within their first 10 years of practice. So again, here, if we're worried about comprehensiveness of services or whether patients are getting the care that they need, we need to be thinking about the broader system context rather than interventions in training or early practice. So just to reiterate, changes in primary care practice are observed across physicians at all stages, pointing to broadly targeted system-wide strategies if the goal is to increase supply or comprehensiveness of primary care services. However, since practice patterns differ over the course of physicians' careers, physician workforces with more physicians early or late in career will have lower volume. So I think that is something that we're seeing in many provinces now. Even before people retire, there's going to be an impact on service volume, and that might help explain our current context. But there's simply no evidence that changes in primary care are driven by early career physicians. That said, understanding practice intentions and choices can still support recruitment and retention and comprehensive longitudinal care. So I'll just very briefly summarize findings from the qualitative component of the study led by my colleague Agnes Grudniewicz in Telfer in University of Ottawa. So in interviews with 90 family medicine residents and early career physicians about factors shaping their practice intentions and choices, many highly value opportunities to deliver comprehensive care in a team-based model, which tends to be consistent with how they train. Like the residency programs, they're embedded within teams, but then when they go to the community, it might be solo or group physician practice. There's interest in alternatives to fee-for-service and something that's perceived to be fair compensation. We hear about the ability to take time off with coverage for your patients without having to line up a locum. The ability to focus on medicine and not running a business is a strong priority for some, not everyone. And then an average, like in general, people are just looking for fulfilling work that responds to community needs. That's why they've chosen family medicine. Again, I won't go into detail, but on our website, and here are some of the qualitative publications that give a little bit more detail and some survey research looking at intentions of family medicine residents, if of interest. One little thing I want to put on folks' radar, and especially folks on Zoom who might be in sort of system planning roles, our findings don't point to gaps in training. But reforms to family medicine training are underway that I believe will have implications for capacity. So the College of Family Physicians of Canada has announced plans to increase the length of residency from 2 to 3 years. Starting in 2027 is the plan, as I understand it. So that will mean that there is a year with no graduating family physicians. It's going to strap capacity for residency spaces, and to offer practice-ready assessments for internationally educated physicians. And I don't think we have good data, but it could shape the appealingness of family medicine relative to internal medicine or other specialties. So I just mentioned this to put it on folks' radar. This is coming up fast, and I don't think we're adequately planning for it. Okay, so I've looked at changing practice patterns, hopefully put to rest the narrative that this is driven by generational effects or different choices. But that begs the question, what other factors might be driving changing primary care capacity and this persistent gap with having more family doctors than ever before, but really challenging context for access. So this is a work in progress. These are findings from British Columbia only, and only up to 2017-18. So I really think we've got more work to do in this area, and this might be something that would be a great point for further collaboration. So, mentioned this before, the population is aging and health needs are increasingly complex. So the bars of people registered for health insurance in British Columbia, it's those older age groups that are growing, that have grown most rapidly over time and are projected to continue to do so. And the turquoise, these are the changes in the number of comorbidities that people are treated for within the administrative data. So what I want to draw your attention to is that this is also changing most rapidly for older adults. I can't tell you if this means that older adults have more conditions and are sicker, or are simply being treated more and monitored more actively, but they're being treated for more. So those segments of the population that are growing most rapidly are also being more actively managed within healthcare. So then when we look at specific domains of services, and these would all require coordination in primary care, these have increased as well, and more substantially among older age groups. So it's those the pink and purple bars. Medical specialists have increased. It's the gradient isn't huge. Surgical specialists, we see a clear gradient by age. Day surgeries, more services are being delivered in the community as day procedures. Prescriptions increasing most rapidly among those 80 plus, in fact, falling in younger age groups. Same thing for imaging, diagnostic radiology, ultrasound, and lab tests, just this very clear age gradient in those increases. And then pointing to the other data, at the same time, family physicians are playing new roles within the system. So while the total number of family physicians is increasing, that increases is almost entirely taken up by emergency and hospitalist services, so that the number of physicians in community-based practice is roughly constant. So at least in the British Columbia setting, when we pull this all together, the volume of those things happening within the systems, referrals, prescriptions, and lab tests per visit with a family physician in the community is increasing really dramatically. So between 35 to 122% increase for lab tests. This doesn't directly correspond to hours worked. We don't have data on that, but it does suggest that per visit, there's more coordination, more administration, just more happening in the background per patient. So to try to pull all this together and discuss factors driving changing primary care capacity and answer that question, if there are more family doctors than ever before, why can't I find one? The work family physicians do is changing. Population needs for primary care are changing. The system in which family doctors work, the systems are changing, and these all sort of interact with each other. So I'm going to take you through these each in a little bit more detail and then talk about some next steps. So the work family doctors do is changing. We've seen those falling visits across all physicians, that the increase in family physicians is accounted for by people in roles other than community-based practice, and more physicians are working in focused practice settings. Population needs are changing, the population is aging, but this doesn't tell us that whole story because it interacts with the fact that people are being treated for more conditions at older ages and getting more services within the system, at least in British Columbia. And then the systems in which family doctors work are changing. So we saw those increases in day surgeries, more healthcare is being done in the community, people at older ages spend fewer days in hospital. And this means more coordination work that would fall to primary care providers in the community. And then we don't have good data on this, but the time it takes to do coordination is likely increasing. So we know that referral processes are complicated. Family doctors spend a lot of time coordinating care in advance of visits with specialists, other specialists. Just even finding people to take referrals can be time consuming. And electronic health records have streamlined some processes, but also mean that it might be that family doctors are doing more of the administrative work themselves. So where to next with this? Hopefully this gives some indication. I'm sort of planning two projects that are underway and that I'd sort of love to tell you about. The first we're calling Paper Cuts, Understanding Changing Administrative Workload within Primary Care. And then the second we'll be thinking about these sort of capacity issues more broadly. So just right now, we've heard the sort of expression death by 1,000 paper cuts to describe changing administrative workload within primary care and within health systems. But we don't have good information about the extent of this project or this problem and what we can do to fix it. So called it the Paper Cuts Project. This will use a combination of administrative data, like I've just shown you in BC, and interviews with family physicians and nurse practitioners, as well as people involved in administrative roles within clinics, to understand their work and try to support strategies for more efficient coordination and delivery of care. We just received notice of funding a week or two ago, and so we'll be starting this in the spring. And we're planning interviews with family physicians in both Nova Scotia and New Brunswick. So for folks on Zoom, we're really open to ideas around recruitment and collaboration. We want to be sure that we include primary care providers working in a wide range of settings. So we can sort of extend this work to look at the volume of services requiring coordination, understand workload and coordination from the perspective of primary care providers in these two provinces, and start to identify practical strategies to make coordination more efficient. So that could include like reducing total volume, improving process efficiency, or looking at how workload is distributed within teams. So that's just getting going now. Can come back and tell you more about it later. And then looking further ahead, there really is this need to support primary care capacity in Canada. So here we're imagining a national study using administrative data in a subset of provinces. So once again, we would go to qualitative data to understand drivers of changing workload more broadly. So not just the administrative workload, but how management of chronic conditions, common conditions is changing, and changes in the patient population from provider perspectives. Then we'll use administrative data to do sort of two things: quantify demand side factors shaping primary care need, like I've shown you here, demographics, complexity, and service intensity. We're also interested in, given access challenges, how does the real demand differ from what people are actually using based on those data we've seen around inequities in access? So what would it look like to actually meet people's needs with respect to primary care? And then to look closely at these supply side factors. So provider demographics, service volume, and details about what family doctors are actually doing to project forward supply side capacity, and pull this together in some simulation modeling that hopefully is more useful for planning than the typical headcounts that we've used up to this point. So that is just in the works and would really welcome opportunities for collaboration or partnership with researchers in New Brunswick. Okay, so I told you I wouldn't spend long. I don't know the New Brunswick context well enough to speculate, but I think in terms of implications, there's three domains I think a lot about. So for medical education, I want to emphasize that findings point to system responses, not gaps in training. And I think we really need to consider the implications of longer family medicine residency. With respect to primary care planning, findings really do point to the need for strategies that expand capacity for longitudinal primary care in the community. I can tell you a little bit more about what that can look like in some settings, and we could talk more about it. And then with respect to workforce, we really do need a more proactive and coordinated strategy for planning that incorporates information both on patient needs and how our workforce is changing. And so I think I have left 20 minutes for questions or ideas or thoughts from people participating. Thank you very much.
So while people put their questions in the online chat, just start to say, are there any questions here at the moment?
Yeah.
Thanks for that presentation. Very interesting. Research going on. One of the hypotheses you mentioned was it looks like physicians are doing more, maybe, if I've interpreted that correctly, like technology is advancing, we have access to better treatments that are maybe more complex, more prescriptions, more lab tests, etc. So it sounds like maybe that could be a case of fewer people accessing care, but maybe getting better care. Is there anything in the literature to suggest that outcomes are better, people are getting better care, the people that do have access?
I don't think we have good data on that. So within the administrative data, just to be very clear, I can say people are getting more care and not better care. I think there has been discussion about medicalization of aging and whether all of these interventions are actually helpful when applied at the same time, and they haven't been studied in the context of substantial comorbidity. So I think there is a very important program of research out there to look at the medicalization and how we're more actively treating people at older ages, and whether we have good evidence of outcomes, that requires a set of clinical skills that I do not have. So I will not be doing that work. But I think like I can only tell you people are getting more care. I can't tell you that they're getting better care. And again, this is just British Columbia. I expect that definitely the generational stuff and the trends in practice volume would track in other provinces as well. This, could be unique to the BC setting, but I suspect we'd see similar elsewhere. So I think it is a separate question, to be honest, about whether this is quality and whether this is needed. But I think even so, we have to plan with these patterns involved or in mind, because that's the current state at least. Does that make sense?
Yeah, for sure.
Yeah,
No,
thanks.
thank you.
Thank you for that question. Yeah.
We do have a question online from Michelle Landry.
Do you want to read it out and I'll just read along?
He's just put his hand up.
Oh, okay.
Yeah, can I ask a question? Can you hear me?
Yes, I can.
Yes, okay. I'm Dr. Michelle Landry. I've done several research on recruitment and retention for family physicians, and for every physician we train in the province. I'm associate dean with University of Sherbrooke. Excellent presentation. If you're looking somebody to partner with, I'll get in contact with you. I'd be very interested. We're working with a research group. I've got with two researchers at the University of Moncton. I'm trying to find retention and recruitment for minority francophone in the area. One of the questions I had is, with all the data you have, there's different settings. Like there's more family groups and solo practice. Could you divide those groups and see if your data show different results for people working family practice and group practices versus solo practices, and the ones with the collaborative practices compared to single solo practices? I'm imagining people who work in collaborative practice, some of the services are offered by social workers or other healthcare professionals, so which might lower the number of patients they're seeing because it's done collaboratively, and they might be seeing more the more acute or severe patients compared to the nurse practitioners seeing the more simple cases. But I don't know if you can have any information on that. Thank you very much.
Oh, that's such a great question. Thank you for raising that. Unfortunately, I don't have great data on that within provinces. It's true that there are different practice models that folks will be working with, and those have changed over time, but we're not able to pinpoint them in administrative data. What I can say is that even just comparing the provinces we've looked at, BC is almost exclusively fee-for-service with very few collaborative models. Manitoba sort of in between. Ontario has had more widespread adoption of team-based care. And we do see the same broad trends with respect to physician service volume across those settings. But as you've observed, the difference may be that where provinces have invested more directly in collaborative models, other people are filling the gaps that we see in these data. The one asterisk, and I kind of am reluctant to say this, it is possible to structure collaborative models in a way that deliver better care to patients, but don't actually expand capacity. So if the model is that family physicians refer on to social workers or physiotherapists to provide care that patients wouldn't otherwise get, that's a great news story. That's good for the health system. We might not actually see changes in capacity. So one of the things I think, if capacity is the goal, we need to be a little bit cautious in how we structure collaborative models so that other people are able to see patients directly, that it's not the sort of referral model, and so that we really are truly making the front door wider and making sure everyone's needs can be met. So I think the trends with respect to physician practice patterns are likely similar across models, but those models are so important in bridging that gap between the changing practice patterns of physicians and meeting patients' needs with that slight caveat that collaborative models can be structured in such different ways. So I'm afraid that didn't answer your question directly, and I'd love to talk a little bit more as there's unique recruitment challenges in the context that you've described. So we'll follow up on email. There are other questions coming through?
I'll just ask a question before we go back
Yeah.
online. So I just had two questions, one kind of in follow-up to what Chris had asked, and then just another one. So in follow-up to what Chris had asked, one of the things that I wondered too is like changing availability, right? So back in 97, it may have not had as many tests available as would be.
Yes,
So the actual
exactly.
volumes, are you controlling for that in any way, or is it just descriptive?
No, it is purely descriptive. So one of the things we played around a little bit, like how you order the tests varies a bit, like just sort of getting a panel in might not have the same increase in workload of things ordered in different ways. But when it comes down to it, like it's one more thing you have to review that you might have to follow up on that's either coming through your EMR or coming across your desk. So as a proxy for amount of stuff happening as part of your work, it's sort of tracked well with our physician collaborators and with our team members. But again, that broader question of what is needed, what is evidence-based, what is duplicated because of inefficiencies within systems. People are getting a test in a walk-in clinic and then following up later, and not actually contributing productively to patient care. We can't speak to in our data. But even if it is that latter case where there's duplicated tests, it's not needed, it's still work. So again, for our purposes, just looking at workload, it works as a measure of quality, or are people getting guideline consistent care or care that's appropriate interpretation of guidelines for their set of complexities. We can't say.
But the increased workload might be a result of just more availability of options to select.
Yeah, so what is required to follow the guidelines and manage a patient with diabetes is different now than it was 20 years ago. The availability of therapies to manage depression in your practice is different now than it was 20 years ago. And all of those things, I think, compound.
All right, and my second question was just a clarification, just based because you had mentioned the period, the cohort and the age effects. So just in the nuance between those, because I didn't really completely understand. So if you
Okay,
could
I'm
clarify
so
that.
glad you asked that. So there's actually sort of different interpretations within the academic literature. There's a interpretation based in sociology. We're using actually sort of a more epidemiological tradition where it really is that interaction. So there's an effect over time that we can attribute to just calendar year. There's an effect that we can attribute to changes over the course of age or career stage. And then is there any interactive effect beyond what would be explained by those two factors alone? There is like a whole literature on this. There's a sort of central identification problem in that one is the function of the other two. And so they're different. We did a whole bunch of work that I won't speak to in detail today about the different approaches you can use to look at age period cohort effects. So in addition to the fairly simple approach we use here, medium polish, there's hierarchical models. You can sort of make some database impose some constraints based on your assumptions. My easy answer to this is we did it all the ways and got the same answer. Had we not, it would have been tough to sort of pick apart the different approaches. But I think the way I think about it, sort of based on my training, is just like, is there an interaction? Is there an effect over and above what would be explained by your career stage and the calendar year that you're practicing in? But it is complicated because it is true that early career physicians are working less than early career physicians did 30 years ago. The same is true about people in practice for 10 to 20 years or 20 to 30 years. So that's the sort of subtlety at the core of this. So people's perceptions aren't wrong, but what the relevant solution is or sort of appropriate policy response is, I think, can be informed by these data. Does that make sense? Yeah.
It would be interesting to understand how the population is consuming services. Do they go faster for care now? See more than one person for their care? Just how this would impact the present practice in family medicine. That's on the chat.
Yeah, that's a great question, and not one I can speak to in full detail. Because it's absolutely possible, like within the descriptive data we have here, that's why I usually incorporate some qualitative work. What are patients' expectations? How does that drive this? That question of how do people navigate systems, and do those systems coordinate and reconcile care so there's not duplication behind the scenes? All of that, again, would people having higher expectations for care and accessing care in more places is consistent with this data, but I can't pull that apart based on the analysis so far.
Okay, another one from the chat. Aging is considered one of the factors that affect the change in types of care provided. or the needs? Is immigration one of those factors also? Do we have data for that?
Oh, that's a great question. So we didn't look at immigration status specifically to this project. But in other work, again, only based in British Columbia, we see kind of varied patterns. So there is a narrative within health services research, the healthy immigrant effect, that people use services, the people who recently immigrated to Canada use fewer services, and then that increases to meet Canadian average over time. But whether that reflects unmet need or really profound barriers to access, I don't think we can say based on our data. So definitely in terms of inequities in access, I think my hypothesis would be that if people's needs were being fully met, that we'd see people who've immigrated to Canada using more services than they do, than is currently reflected in the data. So I think in that work going forward, that would be one of the dimensions we'd want to explore about what's the difference between people's real need and what we see reflected in service use. In my work in British Columbia, we've looked at, for example, who got back in person to see a family physician in the latter part of 2020 and 2021. And it is differential, especially for people who have immigrated fairly recently and who are older adults. It's just dropped off in terms of people getting access. When we look at changes in access to mental health services over the course of the pandemic, we see changes that are differential by immigration group, that again, I think speaks to unmet need and not this narrative. I mean, fundamentally, our immigration system selects for people who are healthy and excludes people who are not. So it's understandable that people who have immigrated might use fewer services, but I think there's still a gap based on our interpretation of the data. Sorry, that was a long answer, but let's get into there. Yeah.
One more from the chat. A patient partner with MSSU would like to know, what is the key message to the public? Because we consistently hear that more family physicians are needed. Should some body of professionals request a change to the potential additional year of training?
Okay. I think there are two pieces that I would love if we sort of tackle together as a public and as people who use healthcare. One is the changes to primary care. That no, it's not just a matter of more family doctors. We need to organize services differently. Everyone should be able to expect that they can get care from a multidisciplinary team in their neighborhood. Our government should be accountable for that. And I think that's something that we can call for as a public. To make that happen, though, I think we need someone to take responsibility for planning for workforce. And this is an area where we've left it up to where the provinces have a role to do this work, but there really needs to be some federal coordination around workforce and support for data. So just as a public, those are the two areas where I would sort of where it would be great for us to speak with a shared voice around expectations for investing in community-based primary care. I'll add one thing that one of the things I find sort of challenging to grapple with my friends and family in talking about these issues, because we're in such a profound, people are experiencing such profound challenges right now. We often get sort of band-aid solutions where they're like pop-up clinics or urgent care centers that are maybe, as we're dealing with sort of seasonal illness and infection and respiratory infections, maybe make sense in the short term. But I think longer term, we really need to demand that people need access to a regular source of care, and that these episodic or sort of walk-in clinic style settings aren't enough and don't fully meet needs. Okay, another rant, but we can talk more. Yeah.
That's okay. We have a couple more. Has the number of students going to med school changed over the years? If yes, what are the specific reasons? Even though we have more family physicians than ever before, how does it compare to the number of residents in Canada currently?
Okay. So there are multiple pieces to that. There's the total number of people at capacity within medical schools. And then there is who is choosing family. Oh, I think I actually have a slide that can speak to the data a little bit. Okay. So what we saw is that there was in the 90s, capacity within medical schools fell. And that's where a lot of our narratives around physician shortage comes from. Over the 2000s, it increased. And in the mid 2000s, we actually saw an increase in people choosing family medicine as their first choice as part of deciding which specialty to train in. So this is reflected in this chart to some extent, which is just the median age of family medicine physicians, and that it had been increasing over time and then plateaued as more younger physicians chose family medicine and entered practice in the sort of early 2000s, but it started to taper off. So there's the question of capacity within medical schools, and that had fallen and has since expanded. And then there's capacity to train family physicians and people choosing to do family physicians or to do family medicine. Again, in the sort of mid 2000s, we were able to turn it around and more people were choosing family medicine, but in the current context that has fallen. And which is kind of reflected in this age figure. But so there's sort of there's two questions there. How do we what is the right capacity for medical school? And then how do we support people in choosing family medicine as a specialty? And then do we have capacity to train residents in family medicine? But we've done it before. We've sort of shifted the balance and shifted the choice. I think we're just at a time where we have to do that again.
Okay. Have you looked to compare your data with data in other countries like Australia, New Zealand, or the UK?
That's a great question. So in terms of the changing service volume, that has been observed in other settings. To my knowledge, there hasn't been specific work around this idea of age period cohort effects or generational changes for us to compare to. So the narratives of like concerns around declining service volume or comprehensiveness are borne out in data sets from other settings, but I can't speak to the specific question around cohort effects in other jurisdictions.
Okay, one last one, and then I'll let Ted ask a question. With early career individuals working fewer hours, is it possible to see what the patient load are for them? Do they have similar patient lists as groups from earlier on?
Okay, so again, I should just be really clear. I can't say people are working less. I can't even say they're working fewer hours. We don't have data on the time spent, but we can say people see on average fewer patients early in their careers, but that is the same as was the case 20 or 30 years ago. And we've looked a little bit into this. There is a natural evolution over the course of family physicians' careers, and that they often take on younger patients when they are themselves younger, and then their patients age with them. But again, that has been a persistent pattern over time and not something that is changing really dramatically. So there is a bit of an association between physicians' ages and the average age of their patients. But again, that's been sort of a recurring pattern. Yeah.
Okay, thanks, Ruth. I'm as chair's prerogative. I have two last questions for you,
Okay.
and then we'll wrap this up. The first one, you talked about changing administrative burden for GPs, tests, referrals, coordination. Do you know how much of that is compensated? Because I'm wondering, like, so the workload increases, but if I'm compensated for it, it means less time for other patients, but I'm still not going to resent the time. But how much of that extra time is uncompensated, which might generate resentment?
That is a great question. And it depends on the payment model. For people under fee for service, it is predominantly uncompensated. There are sometimes like additional, depending on the system, additional bonuses or incentives for management of chronic conditions, for example. But I think it does have a psychological effect when all of this paperwork also feels like it's over and above what you're being paid for. It's a bit of a subtle argument in terms of what is part of the work of a compensated visit or not. But I think, that feeling of having had your patient visits and then just having to crank through paperwork at the end of the day and into the evening and feeling like that's outside of what is being recognized and remunerated as part of your role within the system has a damaging effect. And I think it's also possible to frame this as, like senseless paperwork, but it really is the coordination and glue that is holding our kind of complicated health system together for many people. So that question around how does it align with payment models, I think is important psychologically as well as just in terms of the nuts and bolts. If you're on a capitated model or a salaried model, it may feel more like you're being supported for it. There's a recent payment reform in British Columbia that is now providing a blended model where you get an hourly rate that is intended to reflect administrative workload separate from visit volume. So that's something to consider. My only thing is payment alone isn't going to change capacity. It might shape recruitment, it might shape how people feel valued, but it's not going to be the lever that changes access.
And then my last question, the change from a 2-year residency to a 3-year residency. Is there an evidence base for that
So it's true. Most international comparators in family medicine have a longer residency, so that's often pointed to. There are differences with respect to the training you've received before that across jurisdictions, but it's absolutely true that other comparator countries have longer training. And like also it's just these observations that family medicine has grown substantially more complex over 20 years are consistent with that rationale for longer training. But then one of the arguments that's been used is declining comprehensiveness, that grads are maybe competent but not confident or aren't prepared. That's less consistent with our data. And in terms of an evidence base comparing outcomes across the different training models, I'm not familiar with it. So I think there are good reasons for it, but in the context of current capacity gaps, it needs a really careful look, just so we're planning for it.
That's great. Thanks very much. So your contact details are on the slides. We will make the slides available if they're not already. This has been recorded as well, and the recording will be available once it's processed. So if you've missed this, or you know of other people who weren't able to attend today who would like to see it, please pass that along. Look out for our newsletter. It will be advertised there. And just once again, thank you very much, Ruth, for coming and presenting this really great stuff today.
My
Thanks.
absolute pleasure.